Okay, so now we're going to look at the special populations chapter. So part of the thing is when you're looking at some of this, again, having a pretty good awareness as to how particularly the nervous system works, because as I had mentioned in class, a lot of this is going to focus on stuff related to spinal cord injury. So, again, kind of having an awareness of that. The chapter does explain some of that stuff, but again, having an understanding of some of that basic function. So it may even be helpful to look back at some of just the basic anatomy and physiology of the nervous system that's in your textbook as we move along. So as we look at some of the conditions, so autonomic dysreflexia, it's also known as hyperreflexia. This is a complication of spinal cord injuries to those with lesions above T6. So what happens here is this is above what's called the major sympathetic outflow in the body. And you can actually even still have attacks with those that have injury above T10. And the main issue that comes with autonomic dysreflexia is that the athlete's blood pressure can rise to dangerous levels. So the systolic can go as high as 300 millimeters of mercury, and clinically it could even rise to more than 20 above baseline. So it's important to get baseline measures. One of the things we talked about in class was the pre-participation exam and some of the important points with these special needs athletes, and particularly those with spinal cord injury and that they're in wheelchairs, knowing what their normal resting blood pressure is. So essentially what ends up and what happens many times is you get an imbalanced reflex discharge when there is something irritating below the level of injury. So, an insect bite or a bladder infection are things that can bring about this, or just even a distended bladder can cause autonomic dysreflexia. So one of the important things to note beyond just your basic signs and symptoms is just knowing some of the red flags associated with this, because this is something really important that if you're working with athletes who can be predisposed to this, to make sure that you're able to see this early on and have them get the appropriate treatment associated with it. So something that can be associated with autonomic dysreflexia is what's called boosting. So this is actually a technique utilized by athletes with spinal cord injury to actually gain an advantage over their opponent. So it's actually a performance enhancing technique, but it's a dangerous one. And what it actually does is they actually intentionally induce autonomic dysreflexia for the purpose of enhancing performance, because the idea is with that, it increases their circulation. So we had talked about how, athletes confined to wheelchairs, how their blood circulation doesn't work the same way, obviously, that someone who's not in a wheelchair. But by inducing autonomic dysreflexia, they can actually improve their circulation. However, it's a dangerous thing because of the potential issues associated with blood pressure. So many times what these individuals will do is they'll induce it by either holding their urine or clamping their catheters before an event. They may even go as far as to actually induce trauma to their lower extremity. They may sit on a sharp object or just do anything that could possibly cause autonomic dysreflexia. So it's really important to note that this is it can significantly improve their performance, but it's extremely dangerous and it is unethical. And actually, the International Paralympic Committee actually basically looks at it as a method of doping. So it is actually considered an illegal technique for individuals involved in these sports. Very important to also note any outward signs of doing this because of the potential health concerns that could come about. So then we look at some other issues. So hyperthermia concerns, so there's some thermoregulatory issues associated with those with spinal cord injury. So athletes with spinal cord injury are at a greater risk of heat illness, and they need a very close monitoring of this, because they're not going to dissipate heat as effectively as somebody who's not confined to a wheelchair. Plus, many times sweating is going to be impaired below the level of the spinal cord lesion, so that gives them less surface area to have that evaporative cooling. So when athletes who aren't in wheelchairs and don't have spinal cord injury, the healthy athlete running around is able to dissipate all their heat utilizing their whole body surface area. If sweating's impaired below the level of a spinal cord lesion, it's going to cause that. The other thing to note is athletes with spinal cord injury are also susceptible to cold injury. So while the textbook focuses a lot on hyperthermia, they're also prone to having cold injury as well. So that's something to note. Partially because of the lack of working muscle mass. So they also have less muscle mass working, which is going to possibly also predispose their body temperature to lowering as well. So both kind of the normal warming and cooling mechanisms are not as efficient with these athletes as they are with athletes who don't have spinal cord injury. So there's a condition highlight on hyperthermia. So again, just kind of noting some of the basics. And there are things that in general, it just kind of highlights what are things that are predisposing factors to hyperthermia and ways to possibly prevent it. So that would be an important thing to kind of note from your textbook. Skin breakdown and pressure sores. So since athletes, many individuals with spinal cord injury obviously can't feel sensations, so it makes them susceptible to skin breakdown and pressure sores. So because of the way they have to sit on their wheelchairs, it could cause a lot of pressure on their skin, which then could cause these pressure sores. And there's other things as well. So wrinkled socks, poorly fitted shoes, any of these things where you can have abnormal pressure points on the body can do this, and circulatory problems are going to contribute to this as well. Again, we had mentioned how the circulation for these athletes is not as efficient as it is in a non-spinal cord injury athlete, so that can also slow healing and also increase their risk for infection. So when you think about the position of the body in a wheelchair, that many times, particularly in the wheelchairs used for sporting events, it causes abnormal pressure. So there's a lot of shear and compressive forces on the skin that when you combine that with the moisture from the sweating that they will do, can possibly create an environment for the skin breakdown to actually occur. So really important to kind of monitor for this in the areas of the body where there's going to be pressure. So particularly on underneath where the ischial tuberosities are in contact with the wheelchair, also in the upper back are areas where you can have some abnormal pressure as well. So here's a picture. This is also in your textbook as well, just showing you the different staging of pressure ulcers. So, when you start to see that reddening of the skin, that's kind of a sign that you're going to start to get possibly put the person at risk for a pressure ulcer. So you note the different stages here and how much breakdown in the skin there is. So again, it's really important to catch this early. If you're working with athletes in wheelchairs, make sure that you're monitoring them for this. So also note the signs of infection, because again, this could be something very debilitating and can cause a lot of health issues with an athlete. So again, noting the color, if they do get a lesion, note the odor, because that's also something else that could kind of tell you if you see any black areas around the sore, greenish discharge. Those are all things that you want to look out for in these different types of skin wounds. Okay, spasms. So muscle spasms can occur in athletes with spinal cord lesions above L1. And basically the reason why it's going to be caused by excessive reflex activity below the level of the lesion. So strong muscle spasms in a muscle group can actually go as far as to actually, your textbook talks about this, launching an athlete out of their wheelchair. So this is something that can be very frustrating for athletes. So again, there's various sources that can cause this. Again, sensory input from touching hot or cold items, bladder infections, which are a constant problem with wheelchair athletes and always have to be something that has to be monitored for, any type of infections or skin breakdowns. For female athletes with spinal cord injury, their menstrual period can cause this as well. And this could occur just suddenly. Just, something, just an involuntary jerk of a body part can cause muscle spasms. So this is another, issue with individuals with spinal cord injury that you need to be aware of when you're covering sporting events for wheelchair athletes. So a lot has been mentioned about bladder issues with spinal cord injury athletes. So bladder dysfunction, athletes with spinal cord injury have a neurogenic bladder, which basically means it does not always empty properly or completely, for that matter. This many times can lead to infections, kidney stones, and different types of obstructions within the urinary tract. So many times too, obviously these athletes will have catheters to have them empty their bladder, which many times the catheters themselves could cause infections. It should be noted that not only do many times these athletes have issues with bladder dysfunction, but they can also have issues with bowel movements as well. So in your reading, note your red flags for bladder dysfunction. So kind of make some notes to yourself on that. And also, what are some preventative things that you can do for your clients who have obviously spinal cord injury and where bladder dysfunction. Again, that's going to be part of your pre-participation exam, is to note, what have been the frequency of, or have they had a significant history of bladder infections. Really important to be aware of this. And it's also important to make sure you have their bladder management plan, because you need to be aware of, for instance, facility needs for the individual to make sure that they're maintaining their proper bladder function as needed. Spina bifida is a congenital spinal cord disability. So we're kind of moving on to something a little different here. Still a spinal cord issue, but it's not just focusing on particular complete or incomplete spinal cord injuries. This is something a little different. It's actually an issue where the neural tube fails to close completely, and this usually happens in the first 4 to 6 weeks of fetal development. So this is something that somebody is born with. And essentially what happens is the posterior arch of one or more of the vertebrae does not completely close. So what essentially happens is there's actually an opening in the back part of the spinal column. There's different categories of this. You have muscular weakness and paralysis below the level of deficit if it is a significant deformity. So there's different levels of deformity, and I'm actually going to show you some of the different types. The most common type is what is known as a meningiomyocele, and that is also basically the most severe form, where you actually get a herniation in the back where both the cerebrospinal fluid and a portion of the spinal cord goes into the defect. And there's some pictures of this that we'll talk about. There is a type known as spina bifida occulta that is basically hidden below the skin. You don't actually see it. The hallmark sign of this is either a birthmark, dimple, or a tuft of hair on the person. So literally you'll see a little small patch of hair on their low back, and that actually is telling you that the person might have spina bifida. Now those individuals typically don't have any major issues except for maybe some low back pain from it. But spina bifida occulta is something that's actually below the skin. You can't see it. It's still a defect or an incomplete closure. You might be able to palpate it, but again, most people that have spinal bifida occulta have nothing more than just low back pain. Now, if somebody has one of the other types, which are both major deformities that involve herniation that you can outwardly see, those individuals will have a slightly greater level of disability. So here is a meningial seal. So you see here you have the herniation. The spinal cord does not come through the herniation, but what you have is the cerebral spinal fluid basically fills it. You do have the meninges that come through. So again, orientate yourself to the picture. You can see how it kind of herniates through the skin. So I was mentioning the spina bifida occulta on the previous one. So what you would see with that is you wouldn't have that herniation. Essentially what you would just have is the defect down in the spine, but nothing would herniate through. You would not have cerebral spinal fluid coming through, and you would not be able to see it. As I said, the main characteristic of that is the tuft of hair. You have some other type of superficial deformity, a dimple, a birthmark back there that will do this. This will actually herniate through. However, part of the spinal cord does not come through with it. And here's the most severe form is the meningomyocele, where now not only do you have the meninges and the cerebral spinal fluid, but part of the spinal cord herniates through as well. So this is the one that will cause a much greater degree of disability, and it's also the most common type that you would have. So you'll actually have this defect. The actual spinal cord will come through with it, and you'll have, again, varying degrees of disability, depending on the level, and obviously as you would have with this one, due to the spinal cord herniating through. Cerebral shunts, so this relieves hydrocephalus, so it actually relieves a buildup of cerebral spinal fluid in the ventricles. So this is something that many athletes with spinal bifida will have. So basically it gets, this shunt basically gets implanted into a region to prevent any buildup of fluid from the ventricles into the brain. So it prevents hydrocephalus. So this is something to note. They typically don't pose any restrictions except for avoidance of trauma to the head because of the fact where the shunt basically gets placed. So, it's really important that if an athlete is going to participate in the sport, that this area gets protected. You may notice like a small scar behind their ear, and that's basically showing you where they basically implant the shunt. And again, this is to help relieve that buildup of fluid. So make sure to note the clinical features of shunt malfunction. So you should know based on your pre-participation exam. Again, if you have an athlete that has spina bifida or has a cerebral shunt present, you should be able to note that, and then again note the clinical features of any malfunction that an individual would have. So another issue associated that a lot of people with spina bifida actually have is latex allergy. So latex allergies are common in individuals with spina bifida. So any type of latex products shouldn't come into contact with athletes that have spina bifida. So any type of gloves, you have to watch your any type of rubber tubing that you would use for rehab, strengthening, any type of adhesive bandages, tape, rescue breed. You have to make sure that none of them contain latex. And it's usually a good idea. Latex allergies are actually a fairly common thing in the general population. So, it's not a bad idea to have gloves that aren't made from latex. I always made a habit clinically. I actually just never bought latex gloves. I always bought non-latex examination gloves. So it's important to note that. So look at your red flags associated with, and again, many of the things here are obviously going to be associated with anaphylactic shock. So that gets to be the biggest issue, is you don't want these individuals going into anaphylaxis. So kind of note the red flags of the allergic reaction, because obviously it can actually continue to get worse and worse to the point where you have respiratory compromise. Poliomyelitis, also known as polio. So this is a paralysis caused by a viral infection in the motor cells of the spinal cord. So usually sensation as well as bowel and bladder control are not affected. So those are things that an individual with polio will not have. The severity and degree of the paralysis will be basically based on the number and location of motor cells that actually get destroyed by the virus. So there are a few general medical conditions that are unique to these athletes that you would want to note. Not as much as you would have with someone with a complete spinal cord injury, because as you see on here again, sensation and bowel and bladder control aren't affected with these athletes. So just kind of note some of the issues that you would have in someone with polio. And many people also get what's called post-polio syndrome, which is another thing that could cause problems down the road for those that have even experienced recovery from this. Cerebral palsy is a chronic neurological disorder that causes a lesion in the brain that affects movement and posture. So this is something that occurs very early on in life. It occurs either at or soon after birth. It's not a progressive condition, so basically whatever injury occurred during these times, that's basically the deficits that the individual will have. And it affects the ability to move and maintain balance and posture, because basically you have damage to the areas of the brain that control muscle tone and spinal reflexes. So the classification of this is going to be based on functional ability. So again, there's different characterization of cerebral palsy based upon where the actual lesion takes place in the brain. So many individuals with this have other associated conditions. So they could have hearing problems, deafness, impaired hand-eye coordination. They could have intellectual disabilities and seizures. So the next slide I'm going to show is going to go over the different characterizations of cerebral palsy. So again, kind of note the individual disabilities that these different types will actually have. So characterization of cerebral palsy. So here we have three different types. We have spastic cerebral palsy, we have athetoid cerebral palsy, and ataxic cerebral palsy. So three different types. So the spastic causes hypertonic muscle tone during voluntary movement. So this creates a lot of just movement dysfunction with these individuals because the muscles are in like a constant state of tonus or tightness in these individuals, and they could actually sustain a lot of orthopedic injuries if they're trying to compete in sports. It's important to note this because there can be a lot of orthopedic trauma because of the hypertonicity of the muscles. The athetoid cerebral palsy is basically you have constant, purposeless, and unpredictable movement. So it's kind of these like slow, unpredictable movements that their body actually does because of the lesion in the brain. And then you have the ataxic cerebral palsy, which causes balance and coordination disturbances. So kind of note this specific needs and issues that could come about associated with it. I talked a little bit about the spastic cerebral palsy because there's orthopedic concerns there, which obviously falls under a very specialized area that we deal with, but it's important to note the other issues that could come about with the other types. So seizure control is a common medical issue in athletes in cerebral palsy. So this is something you're going to want to note in the pre-participation exam and make sure you're monitoring very carefully with individuals that have cerebral palsy. So the sports medicine team, it's really important. They could be on anti-seizure medication because this is a common issue that individuals can have. But it's also important to make sure that the individual, your patient, maintains compliance. Sometimes individuals that have, whether it's a person with cerebral palsy or just someone with a seizure disorder in general, many times they aren't good about maintaining compliance with the medication because of the side effects associated with it. So they kind of get frustrated with the side effects, kind of on their own just decide they're not going to take the medication, and they end up having obviously issues then with having the seizure. So it's important to kind of note the different types of medications and some of the issues that could come about with individuals that have seizures, whether even if they don't have cerebral palsy. And we've talked about this in the chapter on neurological issues that you need to kind of note with people that have seizure disorders. Another thing associated with individuals that have cerebral palsy are pathological reflexes. So individuals that have cerebral palsy can exhibit this. So the pathological reflexes they have are involuntary motions or postures. And again, they may not be painful, but they could compromise certain body positions. So again, if it's affecting their posture, structurally for them, it can cause issues. So you need to have communication with these athletes. And again, enhanced by understanding the reflexes. So again, this is where having good background on the neurological system, being aware of reflexes and kind of how they can, impact these individuals, particularly those with cerebral palsy. So again, noting the specific reflexes that can be affected, and again, how you can kind of monitor that is important in managing these athletes. So here are two of the problematic reflexes that individuals could have. There's two others also noted in your textbook. So there's the TLR prone and the TLR supine. So these are basically increased flexor and extensor tones based on change in head position. There's also the asymmetrical tonic neck reflex, or it's also the ATNR. This is known as the fencing reflex because it's activated by rotation and lateral flexion of the neck. So the upper extremities assume what's called the on guard position. So if you've ever watched individuals in a fencing contest, the position that they go in, that's basically what happens. And then there's the symmetrical tonic neck reflex, which has bilateral arm and leg responses to up and down head movements. So kind of note the position of the head for all of these different reflexes and some of the issues that can be caused by them. Okay, so obviously another thing associated with special populations involves amputation. So again, many athletes can still continue to participate in sporting events despite the loss of one or both of the upper or lower extremities. We've seen pretty phenomenal athletic feats by individuals with prostheses lately. So there's certainly, again, a need here for medical professionals working with active individuals to be aware of some of the issues associated with amputations. So one of the things I want you to note from your reading are what the categories and locations for individuals with amputations. So you should be aware of the number identification of where individuals will get classified, and some of the primary medical issues that are associated with individuals that have amputations. So athletes with sensory disabilities, so this makes up a very unique segment of the athletic population. So communication is of special concern to really note what type of sensory disabilities that an individual has, because you may have to find alternative ways to deliver and obtain information. So whether it's a visual impairment, a hearing impairment, it's kind of good to be aware of what type. First of all, if it's a visual impairment, noting, for instance, how badly is their vision impaired and kind of what their special needs are just based upon how severe it is. So as you're kind of going through the sensory disabilities, again, where there's classifications, kind of note that, but also look at the different levels of, for instance, visual disability and the different levels of hearing issues that you can have and some of the problems that could come about with that. So visual impairments and blindness, so any type of issue with visual acuity, and this ranges from visual acuity issues from what's considered being legally blind with partial sight to being totally blind. So now participation for individuals with significant visual impairment can happen. There could be sighted guides, step or stroke counting, a tether or guide wire, any type of source. There's various things, various types of assistive technology. So, kind of be aware of the different types of assisted technology that it gets talked about in your textbook. So, kind of note that with these individuals. Also, again, kind of note, based on the level of blindness, some of the things that may happen. So, for instance, some people who are blind exhibit what are called blindisms. That means they have repetitive movements such as rocking or hand waving, finger flicking. There's no intent to harm in displaying these. There's just some social stigma associated with them. So being aware of those things, if you're working with individuals that have this sensory disability, are important to note. So as you're kind of going through and reading about the different types, just kind of note that. And there's a clinical tips on communication considerations of visually impaired athletes that you would want to note as well. So here's a table I had noted just to kind of be aware of the different types of visual classifications. And again, this is something that is in your text as well that you can take a look at. So again, you have the different levels going all the way from just no light perception at all in either eye up to basic light perception, and varying to just individuals that just have very poor visual acuity based upon the measurement that we had talked about in the chapter on the eye. So take a look at these, and again, as I had said, be aware of some of the other impairment issues that could come about with individuals that have visual impairment. So for instance, many times they have social skill issues that could inhibit their communication. They may have other types of inappropriate physical movements that I kind of made mention to on the last slide. So just kind of make note of those as you're going through your reading as well, and taking notes on that. So an issue is that causes visual disabilities, glaucoma. So this is an increased pressure in the globe of the eye. And basically it's caused by an inability of the intraocular fluid to properly drain. So we know we have fluid on the inside of our globe. That fluid eventually has to drain. If you get increased pressure, that's going to cause pressure on the optic nerve and start to cause visual disability. The visual loss may be gradual. However, it could also be sudden as well, and many times this could even be present at birth. So there's specific things that the individual will complain about that would have glaucoma. So it's kind of important to note that. And it's also important to note other things that could possibly cause increased eye pressure. So note the things that athletes shouldn't do that are talked about. There's a couple things that they make mention of in the textbook that can cause increased pressure in the eye, because again, that's just going to possibly make this worse. And some of the different things that individuals may have to do just to kind of help with their symptoms or issues associated with glaucoma. Deafness and hardness of hearing. So again, this is a different type of sensory disability where, again, there's varying degrees of deafness that an individual can have. So again, kind of note some of the terms. There's different types of hearing loss that a person may have. So the textbook talks about the different types. You have just hearing loss, you have hardness of hearing, you have conductive hearing loss, you have sensory and neural hearing loss. We actually talked about ways to test for that in the chapter on the ear, nose, and throat. So it's up to the practitioner to find ways to communicate, and many times, this could be something that, you find out during the pre-participation exam, to what level the deafness or hardness of hearing is present and how the individual typically learns to communicate. A simple way to communicate is through American Sign Language. So see figure 18.6 just kind of shows the simple alphabet in the American Sign Language. So you don't necessarily have to become a sign language expert. Many times individuals who are deaf or hardness of hearing, you may be able to have shortcuts and abbreviations for words that facilitates things. So if you take a look at this, and again, if you're going to work with special needs athletes, it would be good to be aware of this, but just kind of take a look at the sign language just for the basic alphabet can be helpful, because it can allow you to communicate effectively with these individuals. So here's just a picture of a cochlear implant. So the textbook does talk a little bit about the hearing aids and implants. It would be a good idea to kind of know a little bit about these, because you could kind of then work on your communication barriers and stuff like that and see how they work. So here you have the basic anatomy of the ear, and it kind of shows how a cochlear implant works with hearing. So it shows how the sounds are picked up through the microphone in the transmitter, and how that gets translated into the inner part of the ear. You see the connection to the bones in the middle ear, which will cause the vibration, and then the neural input into the hearing center of the auditory nerve. So if you look at this, you see the auditory nerve and how that picks up the electrical impulses, and then that sends the signal to the brain where it gets interpreted as sound. Then we have intellectual disabilities. So the federal statutes no longer use the term mental retardation. It is no longer referred to as that. There's different. The law basically promotes the term intellectual disability as a way to kind of denote this. And what you have with these individuals, again, varying degrees of reduced ability to understand new or complex information and to learn and apply new skills. So very important that terminology and directions used in assessment and care of these athletes is very clear and concise. You have to make sure that individuals could understand. So again, when you look at the associated medical concerns and issues with these athletes, kind of know what these individuals will typically be deal with. Also kind of note that some of the physical things, now we're going to talk about a specific physical concern that a lot of these individuals end up having, but also kind of note there's varying degrees. Down syndrome is probably the most common abnormality that causes intellectual disability. So throughout the reading, there's various physical and health related things that individuals with Down syndrome have. So make sure to note those in your notes and highlight them as you're kind of going through your textbook reading, because those will be important to note. So as I mentioned, that there are other health concerns associated with individuals. This is one that's kind of highlighted, atlantoaxial instability. So this is a term used to describe laxity in the ligaments that surround the first and second cervical vertebrae. So the atlas and the axis, your C1 and C2, are held together by ligaments. We get laxity in there, and a good portion of individuals with Down syndrome actually have this. The reason why this is obviously such a concern is because it's in the cervical spine, and if there's instability there, it could predispose them for injury. An athlete with Down syndrome should have the presence of atlantoaxial instability ruled out before unrestricted participation in sport is approved. So it's important that if an individual has this, because it will cause restriction, because obviously if they have an atlantoaxial instability, it predisposes them to having a major cervical spine injury. So as I also said, don't only pay attention to atlantoaxial instability while it is highlighted as it's a significant physical issue. Also note the other kind of medical concerns and issues associated with Down syndrome as well. So that kind of wraps up the special population. So one thing to note about this chapter is that while, there are primary issues that we talked about, there's kind of also the secondary issues. So, with the secondary issues, meaning like, for instance, the individuals with cerebral palsy, the seizure disorders associated with them, the issues associated with spinal bifida, the cerebral shunts, the latex allergy. So be able to pair those specific issues with the major bigger pathologies that we talked about. You should be able to make those connections, and as I said, where it's noted, be able to note other medical issues, any red flags that would be a concern. If there are clinical communication points, those would be important to note as well. So as you listen to this, go through your reading, any of those side things, kind of, make notes to yourself or highlight so that you're aware of them.